Well, hello everyone. I'm Jennifer Dodos, the Marketing Director at Predixion Software. Thank you so much for joining us today for our webinar that will be comparing LACE and Predixion Enterprise Insight in the quest to reduce hospital readmissions. Our presenter today is Dr. Michael Mercy. He's a Chief Medical Officer here at Predixion. During the session, we've set some time aside for questions at the end. So if any point during the session you have any questions, please be sure to use the question pane, which is located on the GoToWebinar control panel. So I appreciate your patience this morning, and we're going to go ahead and get started as I hand the microphone over to Dr. Mercy. Good morning, Dr. Mercy.
Good morning, Jennifer. Thank you so much for the introduction. And hello to all the participants out there. I hope wherever you're at this morning, life is going well, and I really appreciate you taking the time to tune in and listen to us talk about predictive analytics and specifically our platform at Predixion, as well as LACE. And looking at that as both of these as valid tools for readmissions, reducing hospital readmissions, but kind of digging down a little deeper into that and understanding a little bit more about how LACE works and can be an advantage or disadvantage, and how predictive analytics works, and then specifically how our platform can help with reducing hospital readmissions. So with that, we're going to kick it off. And again, I'll remind you we'll have time at the end of this talk to have a question and answer session. So keep those questions coming as we click on through, and we'll try and get to them at the end. If we can't get to them at the end, we will have somebody, either myself or someone from Predixion, get back to you promptly with the answer to your questions. So don't feel that because you didn't get called on in class that you're not going to get your question answered. So let's start. First, I always like to go with the objectives. We're going to just briefly talk about why we care about readmissions. I think everybody's probably finally in tune with that, but we'll make sure that we're all up to speed and understand exactly what the issue is with readmissions. Why risk scoring is important in readmission prevention. We'll look at LACE as a tool. A lot of folks are familiar with LACE, but I've found that not so many folks have actually dug deep and sort of understand how LACE was introduced and its strengths and its limitations. We'll then look at predictive analytics as a solution for readmission, and then we'll compare what LACE can give you and what Predixion can give you with respect to the readmission use case. And then we'll move right into it. So why do readmissions matter? I think we're all acutely aware, now that October 1st has passed, that readmissions are a big deal. Obviously very expensive. In my line of work as a medical director and chief medical officer, I'm concerned about readmissions from the perspective of it represents poor quality. It's work that we didn't do correctly in the hospital, and people are coming back to see us, and they're coming back in numbers that cost us a lot of money. So CMS is obviously keenly aware of that and has put into place some incentives, quote unquote, for us to help reduce this readmissions rate. So CMS said, look, we are spending a lot of money on these readmissions, and we think that that's basically a complication, and we shouldn't pay for that, and so we're going to penalize you. And of course, we have just had the first set of penalties imposed. You'll remember, in thinking about how CMS did this, that from 2009 to 2011, they set a baseline. They measured the readmission rate, and they determined, all right, here's what we think is an acceptable readmission rate. And then they actually started measuring hospitals in July of 2011 and finished that measurement in June of this year. And then it took them about 3 months or so, and then they established the penalties. So many folks in the country were notified that they were outside of compliance with readmissions and were going to be penalized up to 1%. I think the key takeaway from that is that we're already 3 months into the next penalty calculation phase. And so that means for us that we only have 3 quarters left to try and fix our readmission issues and show significant improvement and hopefully get above that threshold. And you can see in this slide that they're going to continue to roll these penalties out to 3%, ramping them up. And then, of course, once we get to 2014, CMS plans to introduce 4 new conditions that they'll be measuring readmissions for. So we'll go from congestive heart failure, MI, and community-acquired pneumonia to 4 other as to yet unannounced conditions. But you can bet it'll be something like hospital-acquired infections, length of stay, falls, et cetera. There's going to be something else that they're looking at that they think represent errors in medicine, things that shouldn't happen if we're doing our jobs correctly. So here's what it looked like in the first round. About 2/3 of the hospitals in the country were penalized. The good news is I think that only 8.3 or 278 hospitals got the max penalty, but there were a lot of hospitals, almost 2,000, that were penalized nonetheless. I find it interesting that Mass General in Boston, U.S. News & World Report's best hospital, and I think people can quibble about how the metrics that were used to determine that, but it's certainly out there that they're the best hospital in the country, were hit with a penalty at about 0.5%. So you can imagine that you have not only the dynamic of just being penalized and losing potentially money and a significant income stream for Medicare patients, but then you have the headache of dealing with a PR problem. And how exactly do you explain to your community that you're being penalized for an excessive readmission rate, and what does that say about your hospital? So I think we're all keenly interested in trying to get this problem under control and trying to figure out ways to do that. The total penalty for this round looks like it's going to be about $240 million back to CMS, so that is not an insignificant number. So what do we do? Everybody's scratching their heads and looking around at each other, and do you turn to the emergency room? Do you turn to your hospitalist? Do you look at your outpatient docs? Do you look at your patients and try and develop some sort of system that keeps them from coming back? How do you intelligently address this problem in a way that gets at the root of the problem and, in essence, helps you reduce that readmission rate? So some very smart people from Health Research and Education Trust, many folks know these people, came out with some recommendations in 2010 for a guide to reduce avoidable readmissions. And the very first intervention that they consider is risk screening upon admission and figuring out right when people are admitted who's at high risk for coming back. That's a big statement. For folks to begin to develop an ability to risk screen, what criteria you're looking at, what in your hospital is driving readmissions, et cetera. And then it's interesting to me the next 3 are things that you can do to help intervene to prevent readmissions. But the first thing that you need to do is risk screen. So as we look out there and say to ourselves, who is that patient at risk, and what's out there to help me identify that patient at risk? So kind of first on the scene with this was some great work from Dr. Walraven out of Ontario in Canada. And he published this study that was a validation of an index to predict readmission after discharge from the hospital. And it was an interesting paper because it really demonstrated to people that there were items you could screen for that would tell you that who in your hospital population were at risk for coming back into the hospital. And so what is that index? Well, it's an acronym. We love acronyms in medicine, of course. And so LACE, he thought that this would be something that folks could grab onto. They took a look at literally hundreds of factors for folks when they were readmitted to the hospital and boiled it down to these 4 things, and they could, with these 4 items, accurately risk score patients at risk for readmission. And so the 4 things are the length of stay during the admission or the number of days in the hospital, The A was acuity of the admission. Was it an emergent admission? Did they come in through the emergency room? What was the Carlson score as a measure of comorbidity? What are the other illnesses these patients carry with them that could affect or impact their ability to successfully stay home, and then also, of course, the need for readmission. And then last, another marker as an emergency physician, this one always gets me, but the number of ED visits in the last 6 months. So that is what LACE is in essence. And here's how you calculate a LACE score. This is taken right from their paper. And you can see that for the length of stay, for the acuity, comorbidity, and visits, you're given a point, and the points can add up to a total of 19. So somewhere between 0 and 19, they're going to be able to give you a probability of admission or a risk score. So here's what that table looks like. You see the LACE score on the left all the way down to 19. And then you see the expected probability right next to it. So if you score 19 or above, according to their statistics, you have about a 43.7% probability of being readmitted to the hospital within 30 days. So what are the advantages of LACE? As we want to be people who take a look at this intelligently and say, okay, what are the advantages, what are the disadvantages? Let's roll through the advantages for LACE. First of all, it's incredibly easy to use. It's a straightforward calculation. It's something that conceivably you could very easily enter into your hospital IT system. You could have people calculating it on the chart with a piece of paper. So obviously, I think LACE is fairly easy to determine that score. It has a relatively high accuracy. I'm going to introduce the concept of C statistic. That is something that in the world of predictive analytics we deal with a lot. But it's essentially the ability to predict true positives and your ability to not miss the false negatives. So in the situation of this, the C statistic for LACE is greater than 0.7. JAMA recently published an article looking at validity in models, and they determined that if you are going to use a model, its C statistic needs to be over 0.7 for it to be considered an accurate model and worthy of use. And then lastly, it's fairly inexpensive. It's out there, published. All you need to do is take a look at the table and in some way put that into your system. Fairly easy to do to calculate a risk score. So what are some of the disadvantages of LACE? As you step through the study, you realize that it was a very specific demographic that they examined. I think there were right around 5,000 patients in the study. Most of them were middle-aged, healthy patients. And of course, they're Canadian, so they're in the Canadian healthcare system, which much maligned, but they do have better outcomes than we do. And I'll just leave it alone at that. But they're relatively healthy people in their middle age, and they've been in a healthcare system that they have some access to, and that everyone has availability to get in and get ongoing care. Definitely different in many respects than lots of hospitals in our country who have very sick populations, heavy Medicare, heavy Medicaid, folks who are not engaged in the healthcare system on a regular basis. And because of that, you end up not being able to use this or sort of export this to your experience at your hospital potentially if you're trying to use it across different cohort of patients. It can really only be calculated after discharge. You remember the recommendation, which is to risk score these people upon admission. Well, unfortunately for LACE, you can only calculate the score when they've been discharged. The L in LACE is length of stay, and of course you don't know when someone's admitted how long they're going to be in the hospital for. So you end up not being able to calculate that score until you're thinking the patient's going to go home or in fact is already home. And then the authors themselves in the study said, hey, we understand the limitations of using something like this, and we think until it can be externally validated and looked at in a number of different places, we think it's only useful for quality assurance and really shouldn't use it on individual patients or try to base treatments or interventions on those individual patients based on their risk score from LACE. And then, in my mind, one of the biggest disadvantages of LACE, and I think that LACE was a great study. I think it really sort of kicked off people thinking about readmissions, and is certainly a great piece of research. But one of the things that's frustrating as a clinician is that when I look at those 4 criteria, there's really nothing there that tells me what to do about that patient, how to move forward in preventing their readmissions. Can I go back in time and keep them from going to the ER over 6 times in the last 6 months? No. Can I change the acuity of their admission? It's emergent. There's something going on. They're coming in. It's the horses are out of the barn. Obviously, length of stay, that can't really be changed potentially. And then their comorbid conditions. Are there comorbid conditions? So it's a great marker, and it tells you who might be at risk and where at risk they might be, but then it's left up to the hospital to develop the systems, to develop the science, if you will, or the ability to track down, dig down on individual patients who are at high risk and say, all right, what is it about this patient that's putting them at high risk? So if you look at predictive analytics, and I'm talking about predictive analytics in the biggest sense of the word, including all those folks out there who do predictive analytics, to give you an idea in case you're not familiar with predictive analytics, it's a BI tool that uses data mining to produce a model that will predict possible future states. So BI stands for business intelligence. Data mining, just pouring through all that data. You know that in healthcare we are replete with data. We have so much data, and actually none of it we leverage or use in a way that can really help the patients. I think we all feel that while we collect a lot of data, the ability of that data to be used seamlessly in our day-to-day lives to help make our patients better, lacking. I think everybody would have to say that. So in order to use predictive analytics as your traditional business intelligence tool, you've got to have data scientists to develop these models. And once they do that, they'll export the models to you. But these folks, these data scientists, are in limited supply and high demand, and it takes them time to be able to figure out how to develop the models. It works in other industries, but again, they're not quite the same as healthcare, as many folks will point out. Another advantage to predictive analytics, I think, is that you can identify key influencers for the risk score that you get. So as opposed to LACE, you can actually say, well, here's why you got this risk score. And then the way that it works is they use retrospective data to build models to predict possible future states. And we'll delve into that a little bit later when I show you how prediction works. But this is kind of the state of predictive analytics out in the real world currently. So what are the disadvantages? The model generation is typically one size fits all, so it kind of gets to that LACE problem where they developed a model that works in Ontario for Canadians, middle-aged, healthy, but does it work for everyone? And when you develop a model at your institution, or if you bring somebody else's model in from outside, it may not work as well as you'd want it to. You may not get the accuracy that you need. Generally, these models are static. In other words, they're not updating. So as you move through and increase the your ability to decrease readmissions, readmissions, the model isn't updating. So you're getting old information as things change about the patients who are being readmitted. It requires that you have the data the model needs to drive it. And some people, some institutions just don't have all the bits and pieces that a model needs to be fed in order to give you some accurate predictions. And then, of course, we all know that every hospital system, it seems like, has its own IT system, and trying to get the information out of these IT systems and plug them into models can be difficult. So enter prediction. We have sort of a different thought about how to utilize predictive analytics, and we overcome some of those typical predictive analytic issues. We've got fast model development. We have smart learning models that update themselves as you progress through by taking a look at the data, and as it's changing, correcting the model and making it, continuing to keep it as accurate as possible. We have the ability to interface with any data system. Our data scientists are working with most of the EHRs out there and have built interfaces, or if we don't have interfaces, have the ability to get the data out and into our modeling system very efficiently. And as a clinician, I love this one. The fact that the insights that are generated come from the data at your institution. These are your hospitals, your patients. And as clinicians always like to say, well, my patients are sicker than whatever the study was they were looking at that recommends whatever. They're like, well, my patients are different in some way, shape, or form. This study, what you're telling me to do is invalid. Well, it's hard to argue when you're looking at a risk score on your patient that's generated from that patient's data. Very hard to overcome, and of course, it actually lends power to what you're trying to do. And then we've got a very user-friendly output, something that can be used at the bedside, at the nurse's station, in the doctor's office, and we'll show you a little bit of that later as well. And then we have found in our experience that our models are highly accurate with C statistics well over 0.8. So I want to just back a little bit up in terms of talking about predictive analytics, because this is a new technology for healthcare, and talk a little bit about how we actually plug into the data and how we build models that then you can use. And so we're going to talk a little bit about the building and the distribution of the models, and then we're going to actually look at some of the output from that. And we'll, as a consequence of this, be able to compare how LACE does with respect to predicted readmissions, how Predixion does with respect to predicted readmissions, and compare and contrast a little bit the difference between the two of them as a tool in your hospital to help reduce your readmissions. So the first concept for Predixion I want you to really think about is that we have looked at this in terms of a holistic point of view. We feel that it's not enough to just give you a risk score. What we have to do is give you the whole enchilada with respect to building the models, putting that risk score and the data behind that risk score into the right place in the right hands, help you understand what might be some effective intervention strategies for your patients, drive that into some case management so you can keep those patients out of the hospital, look at that, examine how you've done, just an absolutely perfect performance improvement model, and then iterate on those models and make them more and more accurate. And that, I think, is something that most folks out there are not looking at, is this whole process, because what we're trying to do is improve outcomes, and that's really what our product is. It's something to help you improve your outcomes and drive that for you so that it's automated. It's something that you see happening, but you don't have to be intimately involved in the process of like dragging this data from one of these circles to the other and making everybody sort of work based on the model that was generated. So how do predictive analytics work? So you've got a question today. Let's say, how do I reduce my readmissions? We're going to take a look at the data that you have in your IT system, clinical variables, social factors, all that sort of thing, and find a readmission study cohort. So we're going to find people who were readmitted to your hospital in the past, and most folks have this data. We're going to divide that cohort into a training data set and a test data set. And with the training data set, we take a look at this cohort and we build the model. And we go back and forth until we think we've got an accurate model, and we test it against this set of patients we've held out to make sure that our model is valid and that it's working, that we're able to accurately predict the outcome in a group of people for whom the outcome is known. So another way to say that is, here's your model. You built it based on the demographic of your hospital, people who are readmitted, and we take folks who the model hasn't seen, and we make sure that it's able to accurately predict that these folks would have been readmitted. So once we're convinced that that model's accurate, we'll actually apply that prospectively going forward, determine the probability of readmission, and of course that then allows us to identify those patients and then to begin to develop intervention strategies for those patients and look at the cost and the efficacy. And we'll spend a little bit more time looking at this, at how Predixion does this in a very unique way a little bit later in the talk. So this is how we actually build models. So you're looking at Excel. This is a very common site for many people. Everybody loves their Excel spreadsheets. You'll notice that the ribbon's a little different, and this is actually the Prediction Insight ribbon. And it's you're looking at actual patient data. It's not all the data that's there, but that's sort of a view of it. Unless you think that we're just using Excel and might be limited by the fact that there's only so much data, so many rows you have in Excel. Underneath Prediction Insight, we have SQL Server and Power Pivot, so we're literally able to handle millions upon millions of variables. So don't think that we're limited just by what Excel has here. So as we move through this, the first thing you're going to do is take a look at all this raw data, and of course we know that there's duplicates, there's things that need to be deleted, and you're going to clean that data, and we help you do that automatically. Then you're going to decide, all right, what type of model do I want to build? Do I want to forecast? Do I want to segment my population? Or do I want to classify my population? In the case of readmissions, you're going to pick a classify type model, and you're going to start to build that model. Well, then, of course, as we talked about before, you've got to test that model. You've got to go back and forth and make sure that it's accurate and that it's giving you the output that you desire. And then you're going to take that model and apply it against your population going forward, and then you're going to send that data out. This is the way that we look at testing the accuracy of our models. So these are two charts that basically give you lift and gain, which are statistically speaking ways of talking about accuracy in the models. But built into our program is something that allows you to actually take a look at the models that were built and determine whether or not they're accurate. And I don't want to get too much into the weeds here, but you can take a look at this chart here, which is telling you we built 4 different models. This line here, the leftmost line, is a perfect model. So this would 100% predict everybody who is going to be readmitted. The blue line is chance, so that's a coin flip, the same as if everybody came in and you just flipped a coin to determine if they were going to be readmitted or not. So obviously we'd like to get closer to this line. And you see that all of these models are fairly similar to one another, and you can go in and pick and say, okay, I'm going to use the neural net model. Over here under lift, again, you're looking at a perfectly accurate model, chance, and you're trying to see how close the model you have is modeling this line here. To make sure that you have accurate models. And in this way, you can convince yourself and the folks who are running your IT system that, hey, we built models, it's an accurate model, we've determined this is the one we're going to use, and we go forward. So once you've done that, the model will crank along and take a look at all of your patients, and then it will produce something like this that gives you, for your population, in this case, what are some of the key influencers for people being readmitted? And you're looking at some tornado charts. If it's blue, these are the things that are having an impact on your patient being not being readmitted. And if you look at the red tornado chart, these are some of the things that are helping your patient be readmitted. So blue means these are the things that are having an impact with respect to readmission in a positive fashion and in a negative fashion for red. So these are some of the data types. These are the actual kind of raw data on the left-hand side here that you can see. Some of these don't make an awful lot of sense, so we kind of clean these up and give them friendly names for the output, as you'll see a little bit later. But you can see things like length of stay, facility type, whether they were admitted, what their Carlson score was, if they had weight loss, deficiency anemia, coagulopathy in place, et cetera. So you're beginning to understand some of the richness of the data that you can get versus something that's a little more static. So the other thing that's interesting for prediction is that we allow you to scenario play within this. So you take a look at that data and you can begin to say, okay, based on the accuracy of that model, and if I look at my patient population and I decide that I want to intervene and that the intervention is going to cost X amount of dollars, what is the efficacy of that, and how much money, bottom line, is it going to save me? And we'll look at this a little bit more in depth, but understand that one of the powerful things about what we do in prediction is the ability for you as a clinician, as a hospital administrator, to look at your patient population, look at the number of readmissions coming in, understand the cost of that readmissions, understand if I intervene, with an intervention that costs X amount of dollars, and I have a certain amount of efficacy that I think, keeps patients out 30% of the time, 40% of the time, 50% of the time, you can go back and apply that against your model and see how many readmissions you should prevent and how much savings that will yield you. And we'll look at that in depth as we, just here in a little bit, as we look at what LACE does, what LACE can do for you, and what Predixion can do for you. So here's the comparative. So if you look at LACE, there's a couple of things I want you to see. I apologize, it's small. We're going to kind of blow things up for you. Looking into LACE, we actually did this work. We took some data that we had from one of our clients, blinded that data, and then just ran it against the LACE index to see what would happen. And so you can see here there's a test population of about 10,000 patients, and it identified 1,421 patients who are readmitted. It gave us a C statistic of 0.78, which is actually great, and that's not a bad C statistic. And then if you look at what would happen, the cost at readmissions were about $28 million. So this is across 10,000 patients. If you employed an intervention that cost about $1,000 and was 30% efficacious, you would reduce that by about $2.7 million, or for a cost reduction of about 10%. So that's not too bad. I mean, I think LACE, from the standpoint of just purely being able to accurately predict who needs to be readmitted, if you can figure out the right interventions for them, you could potentially save up to $2.7 million. So if we compare that to what Predixion can do for you, again, same patients, everything's exactly the same here. You'll see that our C statistic is 0.86 versus the 0.78 for LACE, so we do a little bit better than them. And in the same scenario, same intervention, same efficacy, you can see that we reduce the cost about 13.53%, and save you about $4 million. So, you might say to yourself, well, that's really great. I think the thing that's interesting about Predixion is that with that, we are able to change some of the variables. With LACE, again, you're stuck sort of taking a look at your patient population, deciding what you need to do to intervene on those patients. With Predixion, we've given you the key influencers. You begin to understand exactly what's driving the readmission for your patient population as well as for the individual patient. And you can say, maybe I can increase the efficacy of my intervention to 40%, which 10% leap, that's not that much. Again, the intervention we're saying costs about $1,000, and your typical readmission's about $20,000. That's where those big numbers are coming from. So again, we're looking at the C statistic for that, and the fact that it's costing about $28 million at $20,000 per admission. And by just increasing the efficacy by 10%, we now jump up to 22% cost reduction, a savings of about $6.3 million. So you can see the ability to scenario plan to say, okay, maybe my intervention costs more than $1,000, or maybe my intervention costs less than $1,000. Which patients do I want to intervene in, and how effective do I think that intervention is going to be? You begin to get some very rich understanding of how to manage these patients and what things might be effective. So again, to look at LACE, with 30% efficacy, about a 9.73% reduction in cost. At Predixion, with 30%, you're at 13.53. And then if you just move up to 40% efficacy, you're up to 22.16%, which is great news. I think, it's good for LACE. There's some benefit there if you can figure out what to do. And with Predixion, I think you can see there's clearly an advantage that it's better than LACE. And of course, we'd expect it to be better. It's looking at many more variables and giving you a richness of data that is hard to duplicate. So now I want to talk a little bit about how we think we can help increase these outcomes. How do we manage our preventable readmissions? So I'm going to take you through kind of this circle, if you will, and let you understand exactly what Predixion can give you and why you can see so much more than you might with something like just using LACE. So first of all, I think what we want to do is take the data out of the hands of these folks, the analysts, the IT folks, and instead put it into the hands of these folks. And so how do we do that? What's that look like? Well, if we go through Prediction Insight, we'll show you. So what you're looking at here is our healthcare solutions output. This is this could be a screen that you'd see on your computer, on a thin client like an iPad or an iPhone or a tablet of some sort. This is the clinician button. So if we type into that, you can begin to look at your population. So these are patients who were actually admitted to the hospital, to your hospital, let's say. You've got a list here of folks. You can actually look at, okay, of this patient population, who's high risk, who is medium risk, and who is low risk. So you can imagine if you are a case manager, if you're that discharge planner, and you've been tasked with trying to figure out who's at risk for being readmitted, this is something that you could look at on every day. You go to this and say, all right, today I'm going to look at my high-risk folks and understand what's going on with them. So you have these patients here that are high risk. What are the things that are increasing their risk of readmission? Weight gain, hypertension, low albumins, cardiac ejection fraction not measured. What are the things for this population that are reducing risk? Peptic ulcer disease absent. They've had some weight loss. The inpatient admissions for the last 6 months very low. They don't have pulmonary hypertension. Their albumin's normal. And you can do the same for the medium risk and the low risk folks. So that's great. But let's drive it down even further. Let's go to a patient and click on them and see what's going on individually for this patient. Because what we were just looking at was population. So you now are looking on the right-hand side of the screen at the actual demographic information for Eddie Munoz. And 58-year-old female. I don't have any idea why this woman's named Eddie, but I'm sure there's a great story behind it. She's been readmitted. Her readmission score today is 76.5. And these are the list of what she's got in terms of the conditions, ER visits, etc. So let's take a look at what Predixion says are the things that are potentially driving her individual readmission risk. So for Ms. Munoz, it looks like she has cardiac ejection fraction not measured, renal failure is present, fluid electrolyte disorders present, diabetes are present, hypertension is uncontrolled. So this sounds like a fairly sick individual, particularly for 58. What are the things in her world that are actually reducing her risk? Doesn't have peptic ulcer disease, has some weight loss, no pulmonary hypertension, valvular heart disease is absent, and peripheral vascular disease are absent. Now, as a clinician, you're looking at this and you're saying, of course, well, not all these things are actionable. I don't want to give this person peripheral vascular disease and somehow drive their risk down or drive their risk up. So over here under the repredict readmission risk, what you can do is look at the things that we've culled through the data and said, here are things that are actually measurable and actionable, and you can change as a clinician. So again, you're at the bedside, you're saying to yourself, what can I do for Ms. Munoz? Well, it looks like she has a fluid or electrolyte disorder based on what the data has told us. If we take that away and repredict her readmission risk, she drops out of the high category into the medium category. All right, you've done something in hospital for her. We didn't measure her cardiac ejection fraction. Let's measure that and see just where her heart's at. She looks like a pretty sick person. And repredict her readmission risk. And again, the model tells us that that would lower her readmission risk. So you can begin to understand that on an inpatient basis, this is the sort of thing that can help you keep that person from coming back. The other things, of course, with respect to folks coming back are all the things that happen on an outpatient basis. What happens in their home, are they taking their meds, etc. And we've got the ability to help you with that as well. So we'll pop back into the presentation here. All right. So once we've built the model and given you information, put it in the right place, we can begin to decide what are some effective intervention strategies, not only while the patient's still in the hospital, but as moving forward as they're going out. We can literally put together a decision engine for you. So many folks are familiar with the concept of Netflix or Amazon, and it's so frustrating to me that I can be so easily categorized that I go into Amazon and it says, hey, if you bought this, other people who bought that like this, and I'll be damned if I didn't like that as well. We can sort of do the same thing. We can say, other patients who were like this had successful intervention with X, and we think that that might work for this patient, and tell you that, and then drive it forward to your case management, and then look at the outcome eventually, whether, once we get to the 30-day, were they or were they not readmitted, and then we iterate on that and rebuild the model, leading to improved outcomes. LACE and many other risk predictors out there only give you this part. So we're not really in the business of just doing the analytics and giving you that risk score and then letting you try to figure out what to do. We're going to leverage the fact that we work with many healthcare systems and begin to look at understanding how the healthcare process works, and in your hospital making sure that we can get the information to the people who need it in an easy to digest fashion, and then recommend effective intervention strategies for that group of patients, help you manage those patients in and out of the hospital, look at the outcome, and based on that outcome, reiterate on our modeling and just create this great cycle of performance improvement going, leading to improved outcomes. And we think this is something that we're not seeing in the marketplace currently, and we're not really seeing with a lot of our IT systems. If you think about it, a lot of things give us the data or analyze the data, but then trying to get it into the next silo, into the clinician's hands, very difficult. You spend a lot of time building, interfaces to the nurses, to the doctors, etc. And then nobody can decide on what the intervention strategy is. And then the case managers, can be left out of this completely. And then nobody's really looking in a way intelligently at the outcome for these patients and making sure that we're, in fact, improving the outcomes. So we've spent a lot of time today talking about predictive analytics and talking about LACE and risk scoring patients. I think, we've hopefully made the case to you that readmissions matter. The federal government is certainly making the case to people that readmissions matter, and we've got to pay attention to it, and we've got to begin to develop systems that not just help us with readmissions, but help us with the next things that are coming down the pike with respect to, not only readmissions, but hospital-acquired infections, length of stay, managing complex patients with complex disease, and getting them to a point where we can leverage the data that we have to help improve outcomes. So I think we understand what's good about LACE and some of the limitations. It's easy to use, it's relatively accurate, but it's built on a demographic that may not represent your patients. And so if you use it, you've got to be careful and make sure that you understand exactly the limitations of LACE and that you're not applying it incorrectly. Predictive analytics, we talked about the strengths and weaknesses of traditional predictive analytics, and we looked at what prediction does and how we create models. We looked at LACE versus prediction and gave you an understanding of LACE is pretty doggone good with respect to giving you a risk score. We're better. But then what we do is add all of the other components that you need to actually keep that patient from being readmitted to the hospital. That's kind of what we call the Predixion Advantage. So with that, we'll open things up to questions. It looks like I spoke quickly today. We're a little ahead of time. I'm sure nobody minds that we're going a little faster than usual.
No, I'm sure that's the case. Thank you so much, Dr. Mercy. A couple of questions that have come in throughout the session. The first one is related to in-house patients, and this is related to LACE. Can these patients be brought under LACE for possible readmissions and see the avenues to reduce that probability?
So if I understand the question, somebody's asking whether or not LACE can be used on patients who are currently in the hospital, and can it then be used to decrease their readmission risk, which is a great question. I think that you can not use LACE for somebody who's currently in the hospital unless it's on the day you're planning on discharging them, because then you can determine that length of stay. it helps you, I believe, by actually showing you somebody who's at risk, and there's got to be a reason. But LACE isn't very good at telling you what the reason is. So then, as you know, the person who might be tasked with that, you've now got to dig through the patient's records. You've got to understand exactly what it is about them that makes them want to be readmitted. And what we've seen a lot of folks doing is, based on the risk score and the stratification, they develop kind of a shotgun approach to taking care of the patient. So if you're in the high-risk category, everybody in the high-risk category gets interventions A, B, and C. And of course, that adds to that expense. So now, are all the interventions you're using actually going to work for, you know, all of the patients exactly the same? Doubtful. And so I think the important distinction to think about with LACE is that you can get the risk score, but it doesn't tell you what to do about that patient. Next question.
Yes, well, this is kind of a follow-on to that.
Great.
Related to LACE and not being able to get the scores while the patient's still hospitalized. I think what we can do is talk to this about, with prediction, the question is about what do you do with, or how do you deal with the varying diagnosis codes that a patient may undergo during their stay. And I think that ties back to the real-time nature of prediction, if you want to speak to that a little bit.
So you can, with prediction, again, and to understand the question, or restate the question, so you have a patient who's in the hospital, and things are happening to that patient while they're in the hospital. They're undergoing diagnostics, both, you know, laboratory, radiographic. They're having consultants see them. Things are changing for them. So with prediction, you can risk score that patient as they come in and say, oh, they're high risk. And then as you roll, you can, and at that time, you can understand why they're high risk. So you can actually begin to direct the care of that patient based on, partly at least, on what you were told by why that score was high. You know, they were in renal failure. They had an electrolyte disturbance. They were in congestive heart failure. And begin to address those things. And as you do that, their risk will change one way or another. And you can actually model on patients daily. You can model on them hourly if you wanted to, but you know, I think daily is probably the appropriate interval to go. So each day is, you know, Miss Munoz is in the hospital, you can say, wow, she came in with 80% risk of readmission. On day 2, you've made some changes, you've done some different things, and that risk has now dropped to 70%. And you keep doing things, and you can see that risk either going up or down based on what you've done and her response to the things that you've done. So it's a very valuable tool to sort of see how you're doing as you move along. And that's the beauty, I think, of utilizing something like prediction, is it's going to allow you to use that modeling all the way through the patient's stay. And then as you look at a population and you're fixing things in your hospital, you're changing the way that you do things, and that's, of course, changing readmission risk for your population. The model becomes smart and can begin to show that, and then continue to accurately identify those people who are at high risk for readmission. Great question.
Thank you. See, the next question, is this only for use in a hospital setting? Can it be used in a physician office or practice setting?
Absolutely. If you have data, we can predict on it. So it comes down to you know, not only is it great for hospitals, this is great for insurers, folks who again have data. This can be used on an outpatient setting. So let's say you're a case management company and you are in the process of, this is now post-discharge, and you want to understand how they're responding to therapies you are putting in place while the patient's in the outpatient setting. So you can, as long as you have data there, we can predict on that and give you some insights into what's going on. So yeah, payer, hospital, office, outpatient, case management company, if you've got data, we can predict on it.
Okay. And next is, how do you actually deploy at the bedside? Is your app within the EMR, or does the user need to go to other applications? Or to another application?
To restate that question as I understand it, yeah. how do we get that nice screen that I was showing you into the hands of the clinician? And that comes down to, it's probably more of a technical question than I'm actually able to answer from the standpoint of telling you all the piping that has to happen with it. But essentially we're able to tie into your IT systems, and what you saw was something that resides on a server. And the server can be located at Predixion, or it can be located in your hospital, and then it can be very easily accessed through just a series of a login essentially to that server to look at that data. So it's pretty easy. We also have can keep data in the cloud, so if you want to do it that way, you can as well. So what I'm hearing you say, and I believe the question is, how do you get that information from what we've done into the hands of the clinicians? It's literally a login away. We sort of host the platform in a server, tapping into your data, running it against the models, and then outputting it into this very friendly form that can be logged into by anyone who wants to look at it. And it's not just for the clinicians. As a manager or as a CFO or a CEO, there are views that we have that allow you to look at how your whole system's doing with respect to readmissions or anything else you're interested in looking at. So you can kind of look at it at the nitty-gritty level, and then you can look at it at the 10,000-foot level.
Exactly. And just to add to that just a little bit, Predixion does have an open API where we can, in addition to displaying these results and applications on a web browser, we can also integrate with your clinical or business, line of business applications as well to surface those results wherever they're needed in your workflow.
Exactly. Always need a propeller head to sort of answer these questions for you. Just.
Okay. Next question.
If that wasn't enough for you, we can get back to you with more. Okay. Next question. Sorry.
That's all right. Could the LACE index be included as an additional input for prediction? Do you think it could contribute to improve the performance of predictive models?
Absolutely. If that's I just showed you how we were able to calculate LACE, and so if you have those elements in your hospital IT system as discrete data elements, length of stay, ED visits, Carlson score, acuity of the admission, we can completely calculate the LACE score for you on admission, and then we can incorporate that into the model building and use that as just another discrete data point that will help us understand what the risk is for readmission for that patient.
Okay. What data are you bringing into your system while the patient is still in-house? E.g., are you bringing in, and I'm not sure, it's SNOMED, SNOMED-CT codes from the EMRs or lab for meds, or does the model require concurrent coding?
Understood. So if you're dealing with somebody who is an inpatient, and you're looking at what are the codes that are generated as that person's been discharged, those codes obviously wouldn't be available unless somebody was actively doing coding on the patient while they were in the hospital. But what we can pull in, of course, are any codes from a history for the patient. We can pull in laboratory data. We can pull in really any data that you think is important. So part of that question is, what do we say needs to be there? But it really isn't what we say needs to be there. It's sort of what do you have, what can you make available, and what do you think is important for your patients to measure? So the data elements that we can be modeling on and then following and tracking as clinicians after that modeling process are things that you've decided are actually important. Now, we have a data dictionary and things that we think, based on our experience, would be nice to have, but the absence of them doesn't keep us from being able to model and get very good predictions on patients in our experience.
Okay, here's a couple questions I can answer very quickly. One of them was about the article that referenced the CSTAT, if we could make that available, and I'll send it out to the person that requested it. If anybody else is interested in that article reference, just go ahead and log in a question and we'll get that out to you. The other question was related to a replay or the PowerPoint slides for this presentation and their availability. And yes, we will have a replay of this entire session available online within 48 hours. And you'll receive a follow-up email to this that will give you the link to that replay, so it will be accessible for you. So there's those two. See, I'm scrolling through questions. I think we've addressed just about everything. There's a question here related to ETL, and if it's done through a tool, I will have one of our technical resources reply to that with an answer. And then how frequently, this is for you, Dr. Mercy, how frequently is the data, the hospital data, being uploaded in the cloud in order to provide real-time analysis?
Yeah, we have gone back and forth with hospitals about how quickly we need to do that. And, do we need to update hourly, or can we do it as a batch download at, 3 in the morning when the IT systems tend to not be being used quite as much? And we've found that it doesn't really matter that you update the model on an hourly basis. We think that about every 24 hours, batch the data, send it out to Predixion, and then let us do our thing is sufficient. So you're not going to be bothered with sort of constantly uploading, and you don't have to do it every 24 hours. I mean, if you want to, you could go every 2 days, every week, whatever you feel is sort of an appropriate interval for what you're trying to do with the data. So what you'd like to do, we can do.
All right, thank you very much. Well, that just brings us to the end of our scheduled time today. If there are any questions that I did not address during the session, I apologize for that. We will follow up and make sure that everybody has an answer when we go through the transcripts from this. So again, thank you so much for joining us today. We appreciate it.
Thanks, everybody. Appreciate you. Yep.
Yes, and we'll be hosting another webinar in November, which will give everybody a sneak preview into the Predixion 3.0 release that will be coming out before the end of the year. So watch your email for an invitation to that. And again, thank you so much.
The other thing I'll add, Jennifer, is that we are in the process of finishing up a white paper on just this subject as well, looking at the advantages of LACE and predictive analytics and sort of prediction software versus LACE, and what we think are the advantages and disadvantages of that sort of a more expanded version of this talk. So if you're interested in getting more information, look for that probably early November.
Great. Thank you for that. Again, thank you, everyone, and I hope you enjoy the rest of your day.